along with their addiction. So maybe that's depression, maybe that's a mood disorder, maybe they have bipolar, maybe they're schizophrenic, maybe they have, I don't know, some other mental health issue that leads them to start drinking and then they become addicted. So dual diagnosis means they have other mental disorders or dual disorder, two different things going on. It increases the GABA in the brain, which is kind of your feel-good neurotransmitter, so it makes them feel very euphoric. It's 95% metabolized in the liver, so as nurses, what do we have to watch for if we suspect addiction for somebody? Liver enzymes, right? Is their liver functioning? Have they already caused any sort of damage to that liver? Or maybe we're not quite there yet. They often will have co-occurring substance abuse and psychiatric illness. So they might start with alcohol and then it might be their gateway to start doing other drugs as well. So when they start losing their high, or if the reason they drink is to get kind of this feel-good feeling or make them feel better or mask whatever they're trying to depress, whether it's their depression, anxiety, mental disorder, trauma, neglect, whatever's happened in their past, and it no longer can do that, then they might start adding in other substances. 2/3 of the nation's adult population consumes alcohol on a regular basis. 18 million Americans have alcohol use disorder or alcohol abuse. Pretty high percentage, right? 19% of 12 to 20-year-olds drink. The statistics are going down for the age. There's a lot of stats that kids even around age 9 and 10 are starting to drink. And a lot of times that is because familial tendency. So that it's already very socially accepted in the family or in the community that they grow up in. And sometimes that can be with drugs as well. I worked in North Omaha. There is a lot of kids that use drugs at a very, very young age and use high amounts of drugs. Very, very sad. It's part of their community. So it can be a genetic problem. Phenotype, so phenotypes are classified like if it's a part of your culture. So like the Native American culture is said to have a phenotype of alcoholism. They consider that just like if you're looking at, okay, if you classify Caucasians, Asians, African Americans, whatever, all the different cultural groups, Native Americans, one of their phenotypes would be alcoholism. Diabetic, alcoholism, kidney disease. It's just like in their disease process. So part of their culture, we already kind of talked about that, developmental considerations. So again, abuse, neglect, trauma. You hear that over and over again in mental health. They didn't grow up with any sort of coping mechanism. They don't know how to cope. They don't know how to communicate. So they turn to some sort of alcohol to kind of cover up the Band-Aid fix, to make them feel better. Or maybe they grew up in a family where the only time their parents were happy was when they were drinking. So what image do we portray to those children? Children of alcoholics. You have to drink to be happy, right? So it leads to an addictive behavior. They'll also say that people who are less educated, those that live in poverty, are more likely to become addicted. Married later in life, or no, people who don't have any strong relationships tend to turn more towards addictive behaviors. So somebody who either socially struggles might tend to lead towards addiction behavior. They might be your closet drinkers, or maybe the only time they really feel comfortable in a social situation is if they have alcohol in their system, which then could lead to their addiction. So it used in moderation, we know it can have some positive effects. It can decrease coronary artery disease. There's research out there that people drink red wine. It actually helps kind of vasodilate, helps relax them. Or doesn't believe me, I'm not a red wine person, but there is some positive health factors out there in moderation, which means like maybe you have 1 ounce of wine, right, is good for cardiac health. So 1 ounce is not very much, right? So this is where kind of the discrepancy comes in, because people think, oh, wine's good for my health, I'm gonna have a giant glass every night. Well, no, not the whole bottle, but if you drink it in moderation. But what does moderation really mean to people, right? So for females to drink an acceptable 1 drink per day, so that's 8 ounces. That's not a tall boy, that's not a 24 ounce, not a pounder, right? 1 drink per day. Males can have 2 drinks per day. Again, 2 8 ounce, so a total of 16 ounces, okay? To be an acceptable amount, so that means in moderation. Or wine is like 1 ounce or 2 ounces. It's really not very much. Or liquor, 1 ounce or 2 ounce. So really not very much. We know it can cause severe liver damage with chronic alcohol abuse. Malnutrition is a big thing. So people who drink heavily and are truly addicted, what does that do to the absorption in their gut? They don't absorb things like they should. Things are not getting metabolized in their kidneys or in their liver like they should. So they can have a lot of malnutrition problems. What does somebody who's a true alcoholic look like?
Skinny.
Very thin usually. Do they eat a normal diet? Do they sit down and have a meal in a day? No, they are drinking their calories. So they don't get very good nutrition, and they can actually become very vitamin deficient, and especially deficient in thiamine. So an iron deficiency. And if your brain doesn't have enough thiamine, it can actually cause it to not function the way that it should. So they can become confused, they can start to have cognition issues, they can start to have critical thinking problems, problem solving. It overall affects their brain. So long-term alcoholics, we have to sometimes give them replacements of vitamins. So you might hear of people who come in, alcoholics come into the ER, and they get what's called a banana bag. So they get a fluid that is bright yellow in color because it's full of vitamins, including thiamine, nutrients in there to try to replace that they're lacking because maybe they haven't had nutrition for quite some time. So what are some other signs of cirrhosis? How would we know if somebody has true cirrhosis? There's scarring of their liver because they have killed it with alcohol. What? Ascites is more of a later sign. So bloating, ascites. They might have pain. Where's your liver lie? Right-sided upper quadrant pain, abdominal pain, severe bloating. So they might look kind of obtunded in their belly, but really thin everywhere else. What about their skin color? Yellow, jaundice, if their liver truly isn't working. Or they might get just like a grayish color first, right? They do have kind of a discoloration to them. So they can look almost anorexic. What?
Excessive bleeding.
Bleeding is a risk. Why? What is the correlation between your liver and bleeding? I know we've talked about this before. Some of you guys remember a patient we had at Parkson, and she was bright yellow, glowing. She was like 22 years old. Full-blown liver cirrhosis. Like their jaws hit the floor when they walked in and turned the light on in this girl's room. She was very young, and she was there with what? Why was she in the hospital? You guys remember?
Vaginal bleeding.
Vaginal bleeding. They couldn't get it to stop. Passing huge clots. What is the correlation between your liver and bleeding? What is your liver responsible for helping your body produce? Vitamin K. What if you don't have vitamin K? You can't clot, right? So she was passing humongous clots and bleeding large amounts due to her severe liver cirrhosis at age 22. She, I think, went on hospice and died a couple weeks later. Very sad case. So what else do we want to assess for if somebody's liver's not working? What are their stools going to look like? Dark. Their urine will be dark. Ascites. They might have esophageal varices, so we want to ask, are they coughing any blood up? Because that alcohol will erode the vessels within the esophagus and cause them to bleed. And remember, they are not producing enough vitamin K, so they're not always going to clot. So their gums might bleed. What about their nails? How's their circulation going to be? Clubbing, is it going to be, you might see clubbing of their nails. so they're not getting good oxygenation. What else would they look like?
Don't they itch their skin, pick at their skin?
Yes, why? What is excreted on their skin? If your liver's not working, why do they turn yellow? Bile, right? Their liver's not been able to break down this bile, and so it's excreted on their skin and their mucous membrane, so they become very itchy. So they might be constantly itching, they might pick, they might actually have sores on their skin from this constant like picking. So if they get Wernicke encephalopathy, what is encephalopathy? Swelling of their brain. So this is when they're thiamine deficient. So again, they're lacking that vitamin because they don't have any good absorption in their gut, because one, they're not getting good nutrition, and if they do get any nutrition, they've ruined kind of their body's mechanism to digest and absorb like it should, and they have toxins already in their system from their liver not working. So they can't absorb these nutrients. So they can become very confused, very kind of irritable, have kind of slow movements. That's Wernicke's encephalopathy. So their brain becomes swollen, so they can be very confused. So what is one of the first things? You have somebody who you know is an alcoholic, they're thin, they're jaundiced, they have ascites, they come in and they're confused. What might we check? Thiamine levels, because that might be the culprit. They might be deficient enough that it's making them confused. Okay, and then Corsica psychosis. Anyone heard that term before? So this is when true alcoholics are not able to remember. So they have basically damaged their brain enough from their alcohol abuse that it starts to impair their memory and their function. So they might not remember things, they might not remember where they parked their car, they might not remember what they did yesterday, but they'll try to cover it up and make up stories, which is confabulation. So they're fabulating, they're making up things that are not true to try to cover up their disease, is confabulation. So if somebody has Korsakoff psychosis, this is end-stage cirrhosis, end-stage liver disease from enough damage to the liver from alcohol. So in severe cases, they can have seizures, they can have convulsions, delirium tremens, so they can be very, very shaky. It can start to affect their vital signs, so they might have an increased heart rate, increased blood pressure. If these things are not treated, it can become a medical emergency. So they start to become delirious, become very, very confused, very anxious, disoriented, very agitated. They might start to experience hallucinations or delusions. So they might see things or feel things, have tactile hallucinations. Remember, that's when they feel things like crawling on their skin. So they see bugs, or they see things on the floor. They see things floating around, or they hear things. So this is an extreme withdrawal, and if we don't do anything to change it, it could become a medical emergency. If you have a seizure, they could slip into coma and they could die. So these are going to be late stages of somebody withdrawing from alcohol. So when do you expect we would see this severe of symptoms? What time frame? You guys think? Any guesses? So Taylor came in, say her last drink was at 8 a.m. this morning. She left the bar at, what time does the bar close? 2? Left the bar at 2 in the morning. She drank in her car till 8 a.m., passed out. Her friends saw her, brought her in. So her last drink was 8 a.m. So 3 hours ago. Are they gonna be exhibiting these signs yet? No. She's still gonna probably be intoxicated at this point, right? So it's gonna be probably at least 8 hours before her kind of intoxicated level starts to wear off and we start to see withdrawal. So 8 to 10 hours after their last drink is when we need to start assessing for withdrawal symptoms. And then usually like 10 hours and on is when we start to assess, do they have delirium tremens? Are they getting agitated, confused, having more severe symptoms that potentially could become fatal? Okay, so we know that alcohol has several effects on the body. We already talked about the liver. If somebody's intoxicated, they can start vomiting or become very nauseated, right? It's your body's protective mechanism. It knows, okay, this person just ingested large amounts of toxic that is not good for me, so I'm going to vomit to try to get rid of it, right? So people who are intoxicated or drunk might be vomiting, they might be nauseous. They'll have increased blood flow, so rapid heat loss, or are they vasoconstricted or vasodilated? Causes severe vasodilation, right? Their vessels open up. So what is their blood pressure gonna be? Low, right? Pretty low, because they're vasodilated. Their vessels are opened up. They can have slurred speech, blurred vision, loss of coordination, reduced perception, right? When you see people walking around that are drunk, how do they act? They're stumbling, their balance is off, their coordination is off, right? Their concentration is off, they're not gonna be as sharp. They might be slurring their words. Okay? Then as they become more intoxicated and they start to withdraw, what's gonna happen to your vitals? Your heart rate's gonna go up, you're gonna start to vasoconstrict, increase blood pressure. So when we talk about withdrawal symptoms, if it's something that is a depressant, when they're withdrawing, it's going to make them act the opposite way, right? So when we start talking about stimulants like cocaine, meth, those sort of things, when those people withdraw, they're gonna be more low key, right? When they're intoxicated, they're gonna be more erratic. If you have a depressant, when you're intoxicated, it's gonna kind of slow you down. You feel good, right? Life is great, everything is good. When they start detoxing, that's when they're gonna start becoming more agitated, more erratic behavior. So these people are at high risk for hypothermia. You need to check their temperature, check their blood glucose, because they won't be able to regulate their blood sugar. So check a sugar, which somebody said when Taylor first came in, so that was good. So alcohol withdrawal, again, usually begins 6 to 8 hours after the last drink. Okay, so we want to ask or find out from their family member or whoever brought them in or anyone we can. Sometimes you have no idea when they last ingested something because they might be awake but not be able to tell you. And then delirium usually occurs on days 2 and 3. So it's not always 10 hours, it can take up to 12, up to 24, up to 72 hours. So in that 2 to 3 days after somebody is withdrawing is when we need to monitor very closely for that delirium, confusion. Are they having blackouts? Are they seeing things, feeling things that aren't there? Are they experiencing any sort of psychosis? Okay? They can have alcohol poisoning, which is obviously a toxic condition from excessive consumption in a very short period of time, or also known as binge drinking. There's been a lot of young people who have died from binge drinking at college parties, or they use like a dual substance and they OD because they took a very large amount in a short amount of time and their body wasn't able to do anything with it, and so they actually die of alcohol poisoning. It can happen to adults too. It doesn't always have to be teens or college, well, college is adults as well, but young adults, it has happened with older adults as well. So when are we gonna most likely monitor for these DTs or delirium? What do you guys think? Probably day 2, right? But 2 to 3 days. So if somebody overdoses or they're intoxicated, what signs and symptoms are we gonna see? They might be nausea, vomiting, lack of coordination, slurred speech, staggering, disoriented, irritable, just like somebody you see who's drunk, right? I could replace this overdose and just say drunk up there. What does somebody look like when they're drunk? Stumbling, they don't make sense, they might be loud, they might be obnoxious. Are they thinking clearly? Are they able to focus? Is their perception accurate? Do they have a good sense of perception? No, that's why you don't want anyone driving, right? Their perception's off. So how do we diagnose them? We test their blood alcohol level, right? So we can either do this with a breathalyzer, we can take a blood alcohol serum test where they draw their blood and see, okay, how much alcohol is truly in their bloodstream. And then we're gonna just monitor for what symptoms are they showing. When are they gonna start withdrawing? How severe is it gonna be? What do I need to do? We can do the CWAS scale. So there's a slide, I think your next slide has the CWAS scale on it. If they're ready to commit to no longer using alcohol, we can give them disulfiram, the drug anti-abuse, but we have to educate they can't take any mouthwash, nothing that contains alcohol, or they'll get extremely sick when they're on it. They can also take a drug called naltrexone, so not naloxone, sound-alike drug. Anyone know what the drug naltrexone is for? So this will actually block the high feeling that they get in their brain when they take whatever they're addicted to. So they can use this for opioids and for alcohol. So CNS depressants. So it blocks kind of that feel good, that sudden release of GABA in the brain that says, oh, I love how this feeling of this first drink makes me feel. Or drink 18 makes me feel, if they're truly an addict, right? So they can give them a drug called naltrexone, and it helps kind of block that euphoric feeling. So if they don't get this feel-good feeling anymore when they're abusing, then the idea is maybe they will drink less or try to quit, or it might help motivate them towards quitting. So naltrexone is a drug that they'll use. Now it's an opioid antagonist, so if they're taking this drug, one thing you have to know about it is they can't take any opioids while they're on it because it won't work. So if somebody's taking naltrexone and they get in a car wreck and lacerate their arm and they're in extreme pain, if they go to the hospital and they give them an opioid, it's not going to work. They won't get the feeling from the opioid because this naltrexone blocks that drug. It blocks that ability for it to work. And it has a very long half-life. So anyone who's taking naltrexone, they have to be very well educated on if you get hurt, if you're injured, or if you take any opioids, those are not going to work for you anymore. Okay, so this is a CWAS scale. Some of you guys have seen this before. Some of you have maybe done this. Any of you done this in the clinical setting on people? So this is kind of a protocol or a scale that they'll use for people that they suspect are detoxing. So this one is very hard to read, but you guys have good vision. You can see on there. So they assess nausea, vomiting. So do they have mild nausea? Are they vomiting? Or they have like dry heaves, severe vomiting, they can't stop. And then you give them a certain score. They look at how anxious they are. Are they shaking? Are they sweating? So all signs of alcohol withdrawal. So if they have severe sweating, shaking, tremors. So if you were taking care of somebody who's an alcoholic, so let's say now Taylor has been admitted into the unit and we're just monitoring and observing her for safety until we can get her into a treatment center. Are you gonna say, do you have any tremors? Because what is she gonna say? No, right? Alcoholics who've been in the system, they know this scale. And sometimes they know, hey, if my symptoms are worse, I get benzos. And it makes me feel better. Or it'll kind of knock me out for a little bit. So they can often manipulate this scale a little bit if they've been around it. And you'll see that when you guys get out into practice, when you're dealing with people with withdrawal. But it's a good way that we can use it. And if you guys work in areas where you'll see a lot of withdrawal, ERs, ICUs are the main ones where people are withdrawing from drugs. Sometimes it's drugs we've given them, sometimes it's drugs they come in on. Then you'll get very familiar with this score, or with this scale. So then you see, based on whatever their score is, if they have a very high CWAS scale score, you're going to dose them with lorazepam or give them a benzo to calm them down and help kind of reduce these signs and symptoms they're experiencing from their withdrawal. Okay? So CWAS scale, you'll see this in practice. You guys will use this protocol. So are they having hallucinations? Do they have a headache? Are they hearing anything that's not there? Are they alert? Are they oriented? Or are they totally confused? Not making any sense. Can't concentrate. Can't sit still. Very high score. And it's usually a score, if you work in this area, you get very familiar with, and you can look at it and be like, yep, their CWAS is very high. we're gonna give them 2 milligrams of lorazepam. Okay? You can also use what's called the CAGE questionnaire. So this is a very frequent one they use too. So they ask, have you ever feel you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Or do you feel annoyed by how others feel of your drinking is often how they ask it. Do you feel guilty about your drinking? And do you drink first thing in the morning? So what are better ways we could ask this question? Because again, if you have somebody who's an alcoholic and they've heard this once, are they going to be truthful? No, absolutely not. What is a better way we could ask these questions? What do you guys think? Do you drink 20 or 50 beers a day? Does that help us know how many they drink? Maybe they say I only drink 10. Okay, then they're being honest with you. Or if you say, have you lost relationships due to your drinking? Do you have any estranged relationships going on? How accepting is your family of this behavior? Or how accepting is your family of your drinking habits? Or you can say, does your family ever drink with you? No, they hate that I'm an alcoholic. There you go. They just admitted that they're an alcoholic and they have an estranged relationship. So we just have to get really creative of how we can ask this without telling them, I'm gonna do an alcohol assessment on you, alcoholic. Because are they gonna be compliant? Absolutely not, right? We're like, I'm not an alcoholic. Don't judge me. Don't tell my family, right? So we have to be really creative of how can we ask them without asking them, right? Here's another one, masked. So you guys won't necessarily be tested on these. These are just different surveys, different questionnaires, different protocols that sometimes you'll see in the hospital setting. I would say the most common one is the CWAS scale, because really what we care about as a nurse is, are they withdrawing? Are they gonna harm themselves or harm someone else? Do they need something to help calm them down? But those are just on there as examples. So what are we gonna do for somebody who's truly an alcoholic? Depend on the client's needs, depend on their goals. So remember, when we think about goals, this should be something that the patient is helping formulate with the nurse. Okay, so they have to, first of all, admit they have a problem. Step one, admit it's controlling their life, admit it's ruining relationships. So we might have to ask them, like I just said, what relationship do you have with your family? Who can I call that's close to you? If they say, my whole entire family hates me, there's no one to call. There you go. There's your answer. They probably have estranged those relationships. Who do you drink with? That can tell you a lot about a person. I drink by myself. How many of you want to go to the bar and drink by yourself? Red flag, right? Unless maybe you're just a very lonely person and that's your coping mechanism. But most people don't want to go drink by themselves, right? In a healthy situation. Alcoholics will go and drink with whoever or drink at a bar all day by themselves. Okay, so sometimes asking, who do you drink with? Who do you hang out with during the day? Who did you eat lunch with? I don't eat lunch. I drink my lunch. There you go. Will they agree to enter an alcohol treatment facility? Have they ever been to one before? Have they ever done any groups? Have they done anything for their addiction? Before we're going to get them to admit to doing that, first we might have to get them to admit that they truly have a problem. So how are we going to ask that question as nurses? What do you guys think? What are you going to ask Taylor? Now she's over her withdrawing, we've given her her benzos, she's out of her DTs, she's coming back to us, she's now alert, she's oriented, and now we have to figure out what are we going to do for her discharge plan. Let's do that. Who's going to be the patient? Yeah. Oh, have you done it? Lexi just did. Haley did it. Max, did you do it? Who hasn't done the box? Okay, Talisa, you play the patient. You did it, right? Tracy, you did? Who else hasn't done it? There's a few of you. Okay, Abby, you're gonna be the nurse. So Shalisa, you're the patient. You came in totally intoxicated. We gave you naloxone. You punched the nurse. You were in restraints. You got some benzos. You detoxed in the hospital. Now you're alert, you're oriented. You might be feeling a little guilty. We have to figure out where we're gonna send you home. You're the nurse. You guys are gonna deal with patients like this, or you're gonna have somebody in the ICU. Those of you going into ICU, a lot of times these people need a one-on-one. So they might not necessarily meet the qualifications to be in the ICU, but they can send them there because they usually have a lower census. And so now your one-on-one is somebody who's withdrawing and detoxing. Now we gotta figure out what we're gonna do with them. Okay, I'm your nurse. Lisa, you play the patient. You play it up as much as you want. So what is your focus gonna be with communication? What are we gonna do with her? Now we gotta dismiss her tomorrow. So what's our plan?
Do you have a plan for when she leaves here?
No.
Do you have any family or support system that you can bring out to?
No, not really.
Would you be open to doing more treatment on the patient?
I don't know if I would trust myself outside. Okay, so if they said that, I don't know if I can trust myself in my outside world. So sometimes the hospital is a safe place, right? Or inpatient rehab is a safe place. But the problem is, when they leave, they go right back to that same environment, right? So people with true addiction, sometimes they have to get out of the environment, get out of those triggers that got them there in the first place. They can't ever go back to those same people that they were with. Because we send her home, and now her friends are gonna be like, hey, you're back, cheers, right? Right back in, sucked right back in. So people who are in true addiction treatment, you can never give them the trigger that is going to pull them right back into that addiction. So what are we gonna do? What are you gonna do as a nurse? What?
Ask her, can you ask her friends drink or any?
Yeah, why
anyone
not?
who's around here?
Sometimes you have to ask very blunt, very hard questions. Who are you going home to? Is there alcohol in your house? What? How did it become a problem?
I feel like that you can't force somebody to quit if they don't wanna quit.
Right, are
Does that
you
happen?
motivated to quit?
Cause that happened to like in Tyndall too, we had a lady that was an alcoholic and she didn't want our treatment, so we just sent her home.
Yeah,
This is
which
something
have,
we
you'll
can
see
do.
all the time.
Yeah.
We're just throwing them right back into this cycle. See you in 2 weeks, we'll do the same thing. It's true, it happens all the time. Wagner, happens all the time. Constantly, and
Weekly.
it's a revolving door of alcoholics, they're coming in, they get their benzos, they feel better for a couple days, they get some nutrition, they get rehydrated, they get their thiamine, their brain's back in check, good to go.
First thing, go get a sandwich.
Yeah.
Oh yeah, I'm hungry.
It's a source of nutrition, a source of safety. They get some good drugs to kind of bring them off the ledge for a little bit, but then they go right back into it. So this is where it's really hard to be that nurse, because what are we gonna truly do for them? What if they're not motivated to change? Then we can't really do anything, right? We can educate them on being safe, maybe. Like, okay, if you're gonna go out and drink in our community, please don't drive. Please don't put myself and my family at risk. You can create like a crisis plan with them. Have them write down, like, when I'm drunk, here's who I'm going to call. Do you have somebody that will come and get you from the bar? Do you have someone that will prevent you from being in this hospital again? Until you're ready to make that step for commitment. Are you willing to talk to a counselor? They may say no. What if they're begging for narcotics?
Sorry, we can't give that to you, that's a temporary fix.
Okay, temporary fix. What if they have a true issue where they need narcotics? What if they fell on the ice, they broke their femur, and now they're going home? Do we send narcotics home with an addict? How do you think their pain tolerance is going to be? So somebody who's truly addicted, but they need an opioid for true pain, they're gonna need a higher dose, right? Because they have a much higher tolerance for any drug in their system. Now, ethically, as a nurse, we need to treat their pain, right? So at that point, we're treating the problem, not the addiction. And if they're not ready to treat the addiction, then we just need to focus on the problem. But then that's where safety truly comes into play, right? Like, you know, if you take these, you should not be driving. You should not be ingesting alcohol. I know you're gonna ingest alcohol, so have a plan of not to drive, to be in a safe environment where you're drinking. So that's what we can do, is at least try to give them as much education as we can. And maybe what motivates them. Do you have any small children in your life? Do you have, who is important to you? What if you drink and you're taking your opioids and you kill somebody and now you're in prison? You never see those people ever again. You don't get to see them grow up. Maybe that's enough motivation to change their life for them. Okay, what if she almost OD'd? Okay, what if you would have died 3 days ago if we didn't give you naloxone and you died in this hospital and now your family's planning your funeral? Do you want to put them through that misery? So sometimes we have to be very blunt with them and very abrupt, like, imagine your family planning your funeral right now. Imagine the stress you'd put them through. Would your mom ever recover from your death? Or your husband, or your children if they have small kids?
Honestly, a lot of people in that situation don't even think about that. They just think about themselves. Like, I won't die from.
They're invincible, right?
Yeah.
And is all they can think about is how do I get my next drink, my next drug, because this has taken over their whole entire life, right? So it's very, very hard. Okay, you guys can sit down. So we have to, as part of the goals, are they ready for treatment? Are they ready to commit? Do they even admit they have a problem? Because if they don't admit they have a problem, we're not gonna help them fix the problem, right? So assess their level of disorientation or orientation. We can do urine tests, blood samples, how much toxology do they have, place them in a quiet room when we're doing their assessment, be very non-judgmental, and a lot of times they'll have addiction counselors come and talk to these people. Most addiction counselors have lived addiction themselves. And that's why they make really good counselors, because they can say, I truly know how you feel, I've been in your shoes, right? You as the nurse might not be able to say that, because you're not addicted to anything. We hope not, right? So sometimes they'll have them say, we're gonna go have you meet with a group, or would you be open and accepting to go meet with a group of people who've been in your shoes? Or would you be willing to talk to an addiction counselor who was in this hospital room, in this same setting, and went through what you're going through right now? Because sometimes if they can relate to it, they'll do it. Sometimes, not always. Again, they have to be willing to make that step. So safety obviously is number one, monitoring of vital signs, of neuro assessments, their cognition. Are they slipping into delirium? Are they having DTs? Avoid judgment. Nutrition, so we're gonna give them thiamine, a banana bag, make sure that they're not malnourished, give them some sort of nutrition, monitor their labs, make sure they're not anemic, they're not at risk for bleeding. Okay, so here's one of these lovely NCLEX questions of your new next gen. So I threw this on here. So a 54-year-old with a 30-plus history of alcohol abuse is admitted with a fall related to a left femur fracture. The client says, I was drinking with some buddies when I fell down the steps. So we're gonna put in here the interventions that we would do in the first 6 to 8 hours after their last drink, or 8 to 10 hours after their last drink. So you could have a check mark in one box, or you could have it in both. So I want you guys to do this by yourself first, and then we'll kind of talk through this. So just think where you would put, if this was your test question, what would be priority to do in the first 6 to 8 hours, and what would be priority we'd want to look for as later signs. So think of it as kind of early things and later signs that we would do. You guys don't have this, do you? No. So chlorodiazepoxide is a benzo that's usually, more of a longer acting benzodiazepine. We don't use it very often, but it is a benzo. So just pretend that says administer, a benzo or a long-acting benzodiazepine. What do you guys think? If we give it a long-acting benzo, are we gonna give it right away or a little bit later? Or you could do both?
Later.
Or when would you give a benzo to somebody if they're in alcohol withdrawal? What would they have to be showing you to give them a benzo? What signs and symptoms? Shaky, sweaty, diaphragmatic, agitated, maybe nausea and vomiting, maybe some tremors. So would we do this right away? Within 16 hours after the last drink? If they're starting to show symptoms, yes, you would. You could give this right away.
What would you do in this scenario?
In
If this is like a
scenario-
test question, what would you do? 6 to 8 hours or 8 to 10 hours?
What do you guys think?
8 to 10 hours.
I'd say 8 to 10, okay? Seizure precautions.
Both.
Is this gonna be an early sign or a later sign of withdrawal? Late, so go with the longer time frame. Right? They're not gonna probably seize right away unless you're giving them naloxone right away, or Narcan. Then you have to do seizure precautions, but they're alert, they're oriented in this scenario, right? So we're gonna watch for when do they start withdrawing. A seizure would be a late sign that we're gonna see later, right? So that would be your, like, 8 to 10 hours. When are we gonna give lorazepam? Maybe earlier on, right? Maybe within that 6 to 8 hours, if they start to become agitated, shaky, their CWAS starts going up. When are we gonna monitor their blood pressure? I put a check mark by both, right? You're gonna constantly kind of be doing their vitals. If they show any change in their status, then we would redo a set of vitals. So we're looking for any subtle changes. If they're shaking, could be both. Depends, yeah. If they're starting to withdraw, they're gonna start probably to have some shakes. So this could be an early sign, could be a late sign, probably both. Monitor heart rate, I would say both, right? When do we expect a greater change in their heart rate? Earlier or a later sign? Probably later sign. Assess for disorientation. Early. Monitor for delusional thinking. Delusional, those are DTs, which is a later sign. So delirium tremens would be a later sign. Monitor for nausea and vomiting. Either, early on. I'm not gonna put this question on the test, but I just threw it up there as an example.